Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, in this episode, I am going to talk one more topic in basic principles in general surgery, that is wound healing. This is very important for all surgeons because we are the specialists who are dealing with the wounds, either the wounds which we make or treating a trauma case. So we must know the physiology and the pathology of the wound healing. So after watching this presentation, all of you should be able to understand the definition of the wound healing, the classification of the wounds, types of wound healing, the different stages or phases of wound healing, the growth factors involved in wound healing, factors affecting wound healing, complications of wound healing, and treatment of the wound. So, what is the definition of wound healing? Wound healing is the normal body response to injury, either surgical injury or traumatic injury, to restore the normal structure and function of the body. This is what is called wound healing. Wound healing can occur by two processes. One is by regeneration and another one is by repair. Regeneration is the perfect restoration of pre-existing tissue architecture without scar formation. In human, regeneration process is limited to both the epithelium and the liver. Liver is capable of regeneration. Usually, after the regeneration, there won't be any scar tissue. This is one method of wound healing, but this happens only in liver and the epithelium. Whereas the commonest form of wound healing is by repair, inflammatory process, and the four stages of wound healing. This occurs mainly by the proliferation of connective tissues resulting in fibrosis that results in scar formation. So coming to the classification of wound healing, there are so many types of classification. One is the wound may be an acute wound or a chronic wound. It depends on this acute wound follows the orderly steps of repair to achieve the structure and function. Examples are the surgical incision, incised wound by sharp objects, and laceration. Whereas the chronic wound, the process of repair is arrested at the inflammatory phase due to multiple reasons. So the healing is arrested in the inflammatory stage itself. Example, the diabetic ulcer, the pressure sore. You can see the slough there. Yeah, in the floor of the ulcer, it is not clean. You can see the slough. The another type of classification is tidy wound and untidy wound. Tidy wound means neat wound caused by sharp instruments or objects. No devitalized tissue is present in tidy wounds, whereas in untidy wound caused by tearing or by avulsion, this contains devitalized tissue. So these devitalized tissue, we have to do what is called wound debridement, or we have to do splenectomy, or we have to cut out this devitalized tissue from the body. What are the various types of wound healing? So this you can divide it into primary intention wound healing, secondary intention, and tertiary intention. If it is primary intention, usually it is clean incise wound. Example is the surgical wound. Wound is closed by suturing or primarily by skin grafting or a skin flap cover. Okay, this is primary intention healing. The formation of scar tissue is minimal here. Whereas in secondary intention, the wound is highly contaminated and there may be tissue loss also. The wound is usually left to open to heal. So this is the wound is closed by epithelialization, and there is lot of scar formation in this type of secondary intention wound healing. Whereas there is another type of wound healing called tertiary intention. Here also the wound is contaminated, but it is treated by repeated debridement and wound cleaning and all. So after few days, we can do the wound is closed by suturing the skin or by skin graft or by a skin flap after few days. This is what is called delayed primary suturing or primary skin graft. Delayed primary skin graft or delayed flap cover. Okay, we are not doing it initially. We wait for few days, like 3 to 4 days. We have to do wound debridement and wound dressing, wound cleaning and all, and then we can close the wound. This is what is called healing by tertiary intention. There is another type of wound classification depending on the wound infection to these, wounds. It is divided into clean wounds, that is class 1. The class 2 wounds are called clean contaminated wounds. Class 3 is contaminated wound, and class 4 is dirty wound. What are the types of these wounds? Suppose clean wound means sterile field without inflamed or infected tissues is present. There is no entry into the respiratory, GI, or genitourinary tracts. The examples of surgeries like hernia repair, mastectomy, splenectomy, any vascular bypass surgery, in all these surgeries, we are not entering into any of these systems, respiratory system, GI system, or genitourinary system. So these wounds are not going to get infected. Normally, the chances of wound infection is okay 15 to 1.5 to 4.2% only. Okay, usually in this type of clean wounds, there is no need to give any antibiotic, no need for any antibiotic prophylaxis. The next type of classification in the class 2 is clean contaminated wound, where entry into the either respiratory, GI, or genitourinary tract without any spillage. Small bowel or colon resection, cholecystectomy, hysterectomy. Okay, even all these things are examples of clean contaminated wound. Yeah, here the chances of wound infection is 10 to 20. Example, okay, appendicectomy also comes under this one. Here we have to give what is called prophylactic antibiotic because the chances of wound infection is 10 to 30%. Potentially infected wound, but there is no spillage. So, but still we have to give antibiotic to prevent infection in these wounds. So, you have to give only 3 doses of antibiotic. The first dose should be given 1 hour prior to surgery. 1 hour prior to you are going to make the incision, you have to give the first dose. The second and third dose you can give 8 hourly. We have to give what is called triple antibiotic. One antibiotic for anaerobic organism, one for gram positive, one antibiotic for gram negative organism. So usually we give The cephalosporin, third generation cephalosporin for gram positive, for gram negative gentamicin, and for anaerobic infection, usually we give metronidazole. This is the triple antibiotic. You have to give the first dose 1 hour prior to surgery. The second and third dose you can give 8 hourly. Okay, this is for clean contaminated wound. Contaminated wound means there is entry into the respiratory, GI, and GU tract along with spillage from these tracts. Okay, an example are cholecystectomy for cholecystitis, appendectomy, sometimes ostomy, and fresh penetrating wounds. These are all the examples. Here also, because the chances of wound infection is more, you can give antibiotics. And the fourth class of wound is dirty wound. Here already the wound is infected. Bacteria is present even before the operation. Example is abscess, perforated viscous, and penetrating wound. Here we have to give not prophylactic antibiotic, you have to give therapeutic antibiotic, the same triple antibiotic, you have to give 8 hourly for 5 days, not for just for 1 day. If you are going to give the antibiotic just for 1 day, that is prophylactic antibiotic, which you have to give for a clean contaminated wound. If it is a dirty wound, you have to give the antibiotic, the therapeutic dose, that is the same triple antibiotic for 5 days. Coming to the different stages of wound healing, usually it is 3 stages of wound healing are there. It is inflammatory phase, the proliferative phase, and remodeling phase. The early inflammatory phase is also known as hemostasis, where the bleeding will stop the clot formation. That is called early inflammatory or hemostasis phase, the late inflammatory phase, and then proliferative and remodeling. So in each stage, some particular events is happening. Suppose, okay, if it is a inflammatory phase, okay, damaged vessels constrict to slow the blood flow, and then the platelets will aggregate to stop bleeding. This is what is happening in the mainly the platelets aggregate is the most important thing, and that will form the fibrin to form a clot. So that will stop the bleeding. The leukocytes migrate into the tissue to initiate the inflammatory process. Leukocytes, mainly polymorphs, will migrate. In the late inflammatory phase, the neutrophils secrete chemicals to kill bacteria. The macrophages engulf and digest foreign particles and the necrotic debris in the wound. Macrophages also release angiogenic substance to stimulate capillary growth and the granulation process. All these things are started to happen in the late inflammatory stage. All these things is happening between 1 to maximum 4 days. So after 4 days, okay, this is the second stage, that is proliferative phase, where the main cell here is the fibroblast. For the early inflammatory phase, the main cell is the platelets. The late inflammatory stage, the main cell of action is both neutrophil and then the macrophages. In proliferative phase, the main cell is the fibroblast that proliferates in the wound and secretes the glycoprotein and the collagen 3. The epidermal cells migrate from the wound edges. Granulation tissue is formed from the macrophages, fibroblasts, and also new capillary blood vessels, and neoangiogenesis, it's called, will be from the fibroblasts. This is the proliferative phase. In remodeling phase, that is the final stage of wound healing, the fibroblast secretes collagen. That is, now the collagen will become from collagen 3 to collagen 1. The cross linkage will happen in the collagen. The wound remodeling occurs to reorganize the fibers. The wound contracts, increasing the tissue integrity. The tensile strength will go up to 80% of the original strength. The epidermal cells grows over the connective tissue to completely close the wound. This is what is happening in the remodeling phase. So coming to the here you are seeing the same wound healing different stages, but what is happening here is shown here in this hemostasis is the early inflammatory phase where the main cell is platelet that helps in stop the bleeding. The late inflammatory phase, mainly chemotaxis, that is the attraction of the cells like polymorphs and the macrophages will be attracted, that will attracted to the wound, that will initiate the inflammatory processes. Then the proliferative phase, that is the connective tissue regeneration, where the epithelial migration is taking place and proliferation is also taking place. The main cell here is the fibroblast. This is the proliferative or regenerative phase. And the final stage is the remodeling, where the maturation of the scar, collagen 3 to collagen 1, and cross linkage of this collagen is happen, and then the scar will start contracting and eventually it will become mature, but the tensile strength will be only up to 80% of the original strength, and this is what is called the remodeling of the scar, and this is also known as the maturation phase. So the same different steps we are seeing here also in the hemostasis phase or early inflammatory phase. First it is vasoconstriction, then the platelets aggregation that will form the thrombus or the fibrin because of thrombocyte aggregation, and then this fills the wound and the bleeding stops. The inflammatory, late inflammatory or 2 to 3 days, this is mainly it is the the cells will be attracted towards the wound, mainly the polymorphs and macrophages, because of some growth factors like platelet derived growth factor, uh, TGF beta growth factor, platelet factor. All these things will attract the polymorphs and the macrophages to the wound. Okay, and this is the vascular permeability also will increase in this phase, inflammatory phase. Then from third day to third week, it is the proliferative phase, where the collagen will be secreted now. The collagen 3 and the ground substance also will be secreted by the fibroblast, and the new angiogenesis also take place in this one, and re-epithelialization of the wound also occurs. This is the collagen 3 formation. Then in the remodeling phase, the final phase, the collagen 1:3 ratio will be 4:1. That means the collagen 1 will be more, that is 4:1 ratio. Then there will be increase, vascularity will be decreased actually. Wound will get contracted, and then the strength of the scar will increase, but usually it will go up to 80% of the original strength, tensile strength, and maximum 80%. That is what I told, that will be achieved over a period of 12 weeks. And this is another diagram. Okay, I just want to show it to you well. This is the first early inflammatory phase, the late inflammatory phase, proliferative phase, and remodeling phase. The early inflammatory phase, the cell of the predominant cell is the platelet. Platelet aggregation happen, and then this will stop the bleeding. Okay, in the late inflammatory phase, the predominant cells are both the polymorphs and the macrophages and the lymphocytes also. So it is there, and this will the main cell here in the here is polymorphs and the macrophages. So here this will last up to third week, and then the next stage is the proliferative stage where the polymorphs and all will get converted into fibroblasts that will start secreting the collagen 3 and the ground substance. This also produce neoangiogenesis, and that is the formation of granulation tissue, increased vascularity you are seeing here, and then finally the remodeling. The fibroblasts will decrease, the collagen 3 will get converted into collagen 1, and the scar will start contracting. And this is the maturation phase, that is what you are seeing here. So the same thing, again you are seeing the wound healing or the stages of wound healing is very important. That is why I have included so many pictures. So here you are seeing this is the early inflammatory phase or the hemostasis phase where the predominant cells is the platelet. Platelet aggregation happens and that will seal the wound. Bleeding will stop. The late inflammatory phase, okay, here, okay, the fibrin formation. This is the early inflammatory phase. This is the hemostasis phase. So now the polymorphs will predominate, okay, because of the release of the platelet derived growth factor, okay, that will produce what is called chemotaxis or attract these cells to the wound, and then these polymorphs will turn into macrophages in the late inflammatory phase, and then eventually in the proliferative stage the macrophages will get converted into the fibroblasts that start secreting the collagen 3 and the ground substance. This also produce neoangiogenesis, and re-epithelialization of the wound also happens here. In the remodeling phase, the collagen 3 will get converted into collagen 1, and then the scar also will get contracted. The same thing here also you are seeing. I have shown it in so many pictures. Injury, this is the third day, seventh day, 3 weeks, 1 to 2 years. So injury up to third day, it is the early inflammatory phase. Yeah, injury. Immediately after injury, okay, the event is the clot formation and hemostasis. Here, the main cell is the platelet, and then okay, the neutrophils and macrophages also will be attracted. This is what is called chemotaxis by the growth factors to the wound. Okay, and then this is the inflammatory phase. And then in the proliferative phase, the main cell is the fibroblast. Fibroblast that secretes the collagen deposition, and then during the remodeling phase, the collagen cross linking happens. That is, collagen 3 will become collagen 1, and scar also will get contracted. Coming to the various growth factors involved in wound healing, they are platelet-derived growth factor (PDGF), transforming growth factor alpha and beta, fibroblast growth factor, vascular endothelial growth factor, granulocyte macrophage colony stimulating factor, insulin-like growth factor. These are the various growth factors involved in wound healing. The growth factors act on cells by surface receptor binding. Growth factors have different actions on different cells. Chemotaxis for polymorphs, macrophages, and fibroblasts. These growth factors will attract these cells, polymorphs, macrophages, and fibroblasts to the wound. These stimulate angiogenesis, neoangiogenesis. Stimulate fibroblasts leads to replication and proliferation of tissues. Stimulation of collagen synthesis, regulation of extracellular matrix synthesis. All these are the functions of the growth factors. Here in this tabular column, you are seeing various cytokines involved in wound healing. Yeah, these cytokines, broadly pro-inflammatory cytokines and anti-inflammatory cytokines. The pro-inflammatory cytokines are tumor necrosis factor, interleukin 1, interleukin 6, interleukin 8, and interleukin gamma. So these are the growth factors pro-inflammatory. Anti-inflammatory cytokines are interleukin 4 and interleukin 10. You can just pause the video and you can read all these particulars from where it is secreted and all. You can pause the video and you can read it. So coming to the only 4 growth factors are very important. The platelet-derived growth factor is secreted by the platelet alpha granules, macrophages, endothelial cells, and fibroblasts. And what is the function? It attracts neutrophils, macrophages, fibroblasts to the wound, stimulate fibroblasts to synthesis new extracellular matrix and increase the collagenase. Transforming growth factor is secreted by platelet alpha granules, macrophages, fibroblasts, and keratinocytes. This stimulates collagen synthesis and decrease extracellular matrix degradation, attracts fibroblasts and macrophages to the wound. The fibroblast growth factor is secreted by endothelial cells, fibroblasts and macrophages. This stimulates neocapillary formation, neoangiogenesis. Chemo attract endothelial cells and fibroblasts. Vascular endothelial growth factor is secreted by platelets, macrophages, fibroblasts, and keratinocytes. This increase expression in hypoxic stimulation of proliferation of endothelial cells for angiogenesis. That is the main action of this growth factor. Coming to the factors that affects the wound healing, broadly we can divide it into local factors and systemic factors. The local factors that affect wound healing are, suppose if continued pressure or lack of rest to the wound, will affect wound healing. Desiccation and dehydration of the wound, trauma and edema to the wound, infection or heavy colonization of the wound, necrosis of the wound or the soft tissue, incontinence of either urinary incontinence or fecal, leading to maceration of the tissue that in turn will delay the wound healing. Lack of oxygen delivery to tissue also delay the wound healing. The systemic factors are old age, extremes of age, and especially it is old age, obese patient, those who are having chronic diseases like diabetes and anemia, those who are malnourished, those who are having vascular insufficiency, immunodeficiency, those who are heavy smokers, those who are under stress, those who are having poor health. All these are systemic factors that can affect wound healing. So again, these are local factors, these are general factors. So I will just read only this column. The viewers can pause the video and you can read all the things in detail. So the local factors are, it could be because of poor blood supply, local infection in the wound, hematoma in the wound, faulty technique of wound closure, or tension in the wound, lack of oxygen in the wound, all are local factors that adversely affect wound healing. The general factors are, I told you already, this is the elderly age and patient is very ill, debilitated patient. patients who are diabetic or immunocompromised, jaundice and uremic patient, those who are taking chemotherapeutic cytotoxic drugs, and those who are suffering from malignancy, those who are having systemic infection, those who are taking corticosteroid. All these are general factors. Now you can pause the video and you can read the whole thing. So what are the complications of wound healing? What is a scar? It is disorganized collagen deposition with a lack of tissue organization compared to the surrounding normal tissue. That is what is called scar. Usually, during the scar formation, the scar will attain only 80% of the original tensile strength of the tissue. This you must know. Even after days after, see how many days? 63 days after that, the patient is getting only 80% of the tensile strength of the wound. So this is the normal scar formation. And here you are seeing slightly thickened scar. This is known as hypertrophied scar. That means it is not going out of the incision. Whereas keloid is just like a neoplasia. It is constantly growing. So you should know how to differentiate the hypertrophic scar from the keloid scar. So this tabular column will help you. Coming to the genetics, hypertrophic scar is not familial. Keloid may be familial. Race, it is not race related hypertrophic scar. Whereas keloid scar is more common in black than in white people. Sex, it is equal both in female and male patients, whereas keloid is more common in female. The hypertrophic scar is common in children, whereas keloid is common in young age group, 10 to 30 years. Borders remain within the wound in hypertrophic scar, whereas in keloid scar, it outgrows the wound area. Usually, the hypertrophic scar subsides with time, but keloid scar rarely subside spontaneously. The hypertrophic scar occurs usually over flexor surfaces. The keloid occurs over sternum, shoulder, and face. The hypertrophic scar is related to tension in the wound, but the exact mechanism of keloid is not known. So usually you should not try to excise this wound. You can give intralesional steroids, that is triamcinolone injection can be given right into this scar, excessive scar, so that it will get atrophied. So coming to the treatment of these wounds, you have to manage an acute wound. You have to clean the wound. Then you have to explore the wound and you have to confirm your diagnosis. If there are any devitalized tissue, you have to debride it. See, that is what they are doing. They are irrigating it. Then if there is any devitalized tissue like this, we have to do wound debridement. Then if there are any damaged structures, you have to repair those structures. Replacement of lost tissue, if there is any. Then skin cover we can do if required. Skin closure can be done without tension with either by a suture or you can put a skin graft over that. Yeah, skin graft or even skin flap cover. All of the above with careful tissue handling, and meticulous tissue handling is very important, gentle. And while you are doing the skin cover, okay, this is the skin cover, it is permeable for both gases and water, whereas this dressing is not permeable or impermeable to the microorganism. That is what you have to do. So the treatment of wound is you have to the closure of the skin can be done by suturing, skin suturing with non-absorbable monofilament suture, or you can apply stapler. That is the quick way of closure, or you can apply steri-strips. This is the least invasive way of skin closure, particularly used after suture or staple removal suture removal or staple removal, okay, we can put steri-strips. Or we can use skin adhesive like cyanoacrylate. Yeah, this is a chemical. This you can apply so that the wound will be closed. Provide a waterproof antimicrobial barrier. No need of removal of suture or staples if you are using skin adhesive. Here in this column, you are seeing the various examples of wound dressing like absorbent wound dressing. This is the trade name. And hydrogels, hydrocolloids, alginates. Whenever there is lot of discharge from the wound, we can use this alginate dressing. Transparent films, foam dressing, protease modulating dressing, compression wound dressing, antimicrobial dressing, antimicrobial ointments. These are the different examples for different wound dressings. So to recap the whole thing, there are three phases of wound healing. Inflammatory phase, which is divided into early inflammatory or hemostasis phase and the late inflammatory phase, and then the proliferative phase and remodeling phase. Each phase has distinct cell types of predominance. In hemostatic phase, it is platelet. In inflammatory state, it is both polymorphs and macrophages. In proliferative phase, it is the fibroblast. Remodeling also, it is fibroblast. The wound tensile strength will only reach 80% of the normal unwounded tissue. Many growth factors are involved in this wound healing. So thank you very much for watching this video. If you think that this video is very useful, kindly subscribe to this channel and share these videos in your social media. Also click the bell button to get notified regarding my latest video uploads. Thank you once again for watching this video. Uh, Let us meet in yet another episode. Until then, bye bye.